Dr. Varesh and other chairpersons for the kind words and kind introductions for me. So as I already said in inauguration that I have been given somewhat revolutionary topic, means कुछ क्रांतिकारी टॉपिक दिया गया. कुछ क्रांतिकारी मीन्स कि आशुतोष मिश्रा जी चाहते हैं कि मेटफॉर्मिन को क्राउन से हटा करके कुछ और किसी और को क्राउन दे दिया जाए या कुछ रोटेशनरी हेडशिप टाइप की चीज़ें चलना शुरू हो जाएं. सो लेट्स हैव ए लुक. Idea is not so bad. When metformin has been given that position of universal first-line drug, at that time we were not knowing much about the pathophysiology of the diabetes. We were knowing only one pathophysiology. Later on, triumvirate concept have come, and now we are having the ominous octet. Later on, we also got some dirty dozen and sweet 16 kind of the more and more pathophysiologies are being described every day. So this is not a ungenuine demand that we should really think over the merits of the molecule and then we should decide what should be the first line therapy in diabetes. Where I have finished last year in my talk, I would like to take some inspiration from that talk and would give you some of my ideas regarding this concept. First of all, there is no conflict of interest. So I am talking for none of the interest, only for the interest of the patients and listeners, those who are my colleagues. So we all know about the non-stop diabetes. World population of the diabetes is increasing ever. We are now 415 million and 642 millions are going to occur. Once upon a time, we were having only two drugs of the diabetes, that was metformin and sulfonylurea, but we were not so much of the diabetics. But now we are having so many things in our armamentarium, including insulin, including GLP-1 array, SGLT2 inhibitors, and many more. But despite that, every year by year, population of the diabetes, population of the complicated diabetes, and uncontrolled diabetes is increasing and increasing. Why? Something wrong is somewhere. कहीं ना कहीं कुछ गड़बड़ है हमारी स्ट्रैटेजी में. Because of what? Annual increment is the 2 million. Total diabetes population is more than 69 million in India, and in India it is the annual increment is the 2 million every year. Mortality rate is doubled in the individuals with diabetes, despite our all efforts. So despite having more options to treat diabetes, we are increasing in the mortality, we are increasing in the diabetes complications. Number of uncontrolled diabetes are increasing, rate of complications increasing, expenditure is increasing. Existing treatment strategies have been unable to stop the progressive course of the disease and prevent the development of the chronic diabetic population. The big question is why? Do we need to change our treatment strategy? The one option is that customized first line treatment. Why? Because first line treatment is that therapy which remains with the patient for the longest time. So if we really customize it, if we really start it or put it like the need of the patient, then probably we may do justice and probably we may stop many of the patients from the complications. Because every diabetes patient behaves differently. Every diabetes patient is having underlying pathophysiology different. Every diabetes patient progresses differently. What we were earlier knowing that almost 2-3 kinds of the diabetes was there, like type 1 diabetes, type 2 diabetes, somewhat some people were knowing about the MODI, LADA, but not more than that variety. But later on we could understood that diabetes is quite heterogeneous. It is not a one kind of the progression of the disease. This is not a one kind of the behavior that disease progresses. It is highly heterogeneous. Existing treatment guidelines are limited by the fact that they respond to poor metabolic control when it has developed, but do not have means to predict which patient will need customized therapy. Evidence suggests that early treatment is crucial for prevention of life-shortening complications because target tissues seems to remember poor metabolic control decades later, what we call it the metabolic memory. So all diabetics are not the same. So that's why we cannot put the similar therapy for all the diabetics. In this picture, you can see that for a fair selection, everybody has to take the similar kind of the exam, please climb that tree, and every animal cannot climb that tree. So the same thing happens with the diabetic patient. Every diabetic patient is not the same. So same therapy may not be the ideal first-line therapy for every diabetic patient. So does it really make difference? Yes, it makes difference. As I already said, earlier we were knowing that diabetes is only of the 2-3 kinds of the varieties, but now we should know that diabetes may be of that various varieties. It may be of the different varieties, may be of the different progressions. One may be the severe autoimmune diabetes, another may be the insulin deficiency diabetes, insulin resistant may be the primary pathology underlying the diabetes, obesity related diabetes, and somewhat age-related diabetes has also been seen. And all these different kinds of the diabetes may require different strategies to get with. How these groups behave differently? Here we can see that all these groups of the diabetes are greater than those achieved by the sulfonylureas, and insulin could be noticed with the metformin, and reduction sustained throughout the 10 years. That was the most important thing which could be seen with the metformin. Cardiovascular effects of the metformin, there are further reasons to consider an old drug as a cornerstone in the therapy of the type 2 diabetes mellitus. Metformin has also been found to be the cardiovascular protective, macrovascular complications protective, as well as the microvascular complications protective. So for all these reasons, metformin is carrying the robust data for the cardiovascular safety. That's why it has been always remained a favorite drug for all the people, those who are looking forward a better outcome for a patient. Newer avenues has also been unleashed with the metformin, like, as you all know, diabetes prevention of the cardiovascular disease, PCOS, gestational diabetes, NAFLD, cancer, obesity, anti-aging, neuroprotections, Alzheimer's disease. Even the metformin has been found to be beneficial. Some new users of the metformin has also seen at the low risk of the incident cancer. Metformin use may be associated with a reduced risk of the cancer. So whenever you are thinking for a drug which should be started into the early age of the patient as a first-line therapy, you must like that a drug should be there which should protect your patient from all corners, provide the safety from all corners, not from the one angle. It should be effective from cancer also, it should be effective from the dementia also, it should be effective from the cardiovascular safety, from the renal outcome, from all kinds of the outcomes could be available there. Metformin and NAFLD has also been found to be the NAFLD. It is proven for a safe for the not only for the NAFLD patient, but also has been seen improving liver biochemistry and metabolic syndrome features in the patients of the NAFLD. As far as the thyroid function is concerned, the effect of metformin on the hypothalamic pituitary thyroid axis in patients with type 2 diabetes and amiodarone-induced hypothyroidism has shown that metformin treatment may bring clinical benefits to the patient with amiodarone-induced hypothyroidism and poor tolerance of the exogenous L-thyroxine. And these also indicate that the effect of the metformin on hypothalamic pituitary thyroid axis activity is partially related to the thyroid function. So metformin effects on the vascular protection, you can see it here, number of studies which has shown that it is vascular protective. So another question arises, do we really think metformin is losing its crown? Do we really think that king is getting challenged from many corners? Yes, king is always getting challenged from the many corners. Whosoever is at the top post, he always gets the challenge. But you need to think whether it is the right time to dethrone the king or share the throne with the others of the king. So question is again there, SGLT2, GLP1 and metformin. Is it time to customize the first line anti-diabetics? Sometimes there are no perfect answers, just the perfect questions. So this is just a perfect question. Answer is definitely lying into the future. Cardiovascular disease safety of the oral antidiabetics in diabetes qualifies to this scenario. Clinical experience and case-to-case variations may govern the practice till we have more scientific and real-world data. Although SGLT2 inhibitors and incretin-based therapies are emerging as potential initiators, but they cannot be taken as universal choice to initiate therapy. Metformin also has few gray areas for its use like anemia, vitamin B12 deficiency, which matters a lot in country like India. But still, it is difficult to get it away. So treating diabetes is not a hat, and one size of course does not fit all, but we need to think more in this perspective. Thank you very much for your kind listening, and again,